be here in Yaba. It's one of my favorite places in Lagos because of the innovation, because of the energy, because of all the cool student hangouts, and I'm really happy to be here today. So today I'll be talking about something that I think is close to everybody's heart, because I'm sure that there's nobody in this room that has not been affected in some way, shape, or form by the Nigerian healthcare system. When I was in my year of medical school, my youngest sister, came to Nigeria, and whilst we were communicating with her, she became quite sick. She became critically ill, and we needed to move her from one area to another area, back to Lagos, one of the larger hospitals where she could receive more advanced treatments. And like almost 1 billion people all over the world, she found herself in the wrong place at the wrong time. So it's not as if the help she needed was not available anywhere, but it was just not available in the place that she was. So we tried to help organize this air ambulance service for her, but there was nothing that we could find in West Africa. So whilst we're organizing the air ambulance from almost 7 hours away in Johannesburg, she died. And I decided to start working on this problem of distance, of people being in the wrong place in the wrong time, with central hospitals available somewhere, but sometimes many hours or even days away from where they need to be. But I realized on moving to Nigeria that healthcare was a much bigger problem than I had originally anticipated. And today I'll be talking about fixing healthcare in Nigeria, which is the title of my new book. So in 1942, a British politician wrote a very, very famous paper called the Beveridge Report. And he hypothesized that there were 5 main problems in British society at the time: want, disease, idleness, ignorance, and squalor. But the last and most important one was disease. And he hypothesized that if they could solve disease, then they could have a much healthier, wealthier nation. And it was on the back of this report that the NHS was created, to provide gold standard, world-class healthcare to everybody, regardless of their ability to pay at the point that they were accessing the service. So let's look at the Nigerian context and see how well we've been doing in terms of healthcare. So you can see the first graph at the top is the number of people, the blue one, is the number of people that die from road traffic accidents in Nigeria compared to other developing countries. And you can see Egypt on the far end, the number of people that die in Pakistan, the number of people that die in Mexico, the number of people that die in Turkey. You can see the United Kingdom next, and Nigeria is way up here. So you can see that Nigeria has an abnormally high number of people dying from road traffic accidents compared to obviously developed markets, but even compared to other emerging markets as well. This is the number of babies that die. And again, I looked at Sweden, I looked at another emerging market, Brazil, there is China, there's South Africa, and again, Nigeria has an abnormally high number of neonates, that's babies in their first few days to months of life, dying because of our poor healthcare system. And here we have the spending per citizen. So in Norway, they spend about $6,000 per citizen. So that's the budgeted amount for every single citizen in Norway. They have an allocation of about $6,000 for healthcare. In the UK, there's about $3,000 for healthcare. In Nigeria, we budget about $6 per person for healthcare. So I'm sure you were thinking, okay, that it's not that bad, that you're comparing us to countries like Brazil and Turkey. These are like, we are still emerging. Maybe these ones are emerged. But even when you compare to some of the most dangerous and conflicted areas in the world, such as Iraq, Afghanistan, and Syria, you can still see that in terms of the number of children that die, Nigeria has a seriously problematic healthcare system. There was a WHO survey done a few years ago, and the WHO survey found that there are only 4 to 5 countries in the entire world with worse healthcare systems than Nigeria. So this became my mission, to try and look at new solutions, to try and look at the statistics with a new lens, and to try and find out what the issues are, and obviously, because of the budgetary constraints we have, how we can do not just more with less, but maybe even better with less. So these are the 5 pillars of healthcare that I've come up with, the 5 major issues that I feel that if we could fix, we could have something closer to a world-class healthcare system and maybe move up that ranking slightly so we're not competing with Iraq and Afghanistan and Syria. And the first one is primary healthcare expansion. The second one is tertiary healthcare centralization. The third one is a focus on maternal and child services, particularly because of some of those worrying statistics that you saw about the number of children that die in Nigeria. The fourth is task shifting, so looking at roles that perhaps were traditionally performed by doctors, and perhaps looking at ways that we could train other healthcare professionals to do those exact same roles. And the most important and last one is sustainable healthcare financing. A lot of our healthcare problems are not necessarily clinical, they're economic. And we need to look at the economics of our country, we need to look at how we spend money, and see if there are any ways that we could more efficiently distribute resources. So the first one is task shifting. And the reason why I advocate so strongly for task shifting is because of simple statistics. You can see that in countries like Greece, there's 116 doctors for every 100,000 people, a surgical specialist for every 100,000 people. In Germany, they have 112 doctors for every 100,000 people. In places like the US, slightly fewer, they have about 54 doctors for every 100,000 people. In Nigeria, we have 1 doctor for every 100,000 people. And if you look at a West African context, because we fly a lot around the region, we're operational as an air ambulance in 11 countries, Mali, Chad, Togo, you can find 0.5, 0.3, 0.1 doctors for every 100,000 people. So how do we approach the same level of healthcare as people that have 116 per 100,000 without shifting the responsibilities, or at least some of the responsibilities, of a typical doctor to perhaps the community pharmacists, biomedical scientists, biomedical engineers, people that have studied the sciences and are well-versed in human science and pharmacology, but perhaps don't have this fancy medical degree. And there's good evidence behind it. So there was an article written in the Human Resources for Health journal that showed that non-physician healthcare workers are actually sometimes even better than doctors at performing traditionally medical tasks. The second big point I made was about primary care. And in my book, I talked about Dangote and the fact that he only has 2 factories in Nigeria that are able to supply most of West Africa. And in those factories, you have every possible, I mean, it's a field trip going to Obajana because you have every single possible resource needed for the production of cement. But the lifeblood of his company, what makes the company work, are not those 2 factories. They're the people on the roadside selling to people in their communities, enabling people to make their small bungalow, do their small wall, do their small BQ. Those are the people that are actually the lifeblood of Dangote's company. And you can see that in all the adverts, their staff are going to markets to give these people awards because these are the people that push the sales. And in the same way, primary health care healthcare in the communities can meet 90% of our healthcare needs, and it's far cheaper than tertiary care. And it's local, it's in the community. Not everybody needs to go to Obajana or the Obajana hospitals to get healthcare. Most people, for majority of their healthcare needs, can actually be met quite cheaply and efficiently in their communities. So expansion of primary healthcare, even more so than you see in the developed world, is key to being able to get the standard of healthcare that we need. And universal healthcare coverage, of course, is based around primary healthcare, not management of disasters and catastrophes. This is the big issue: sustainable healthcare financing. Now, Nigeria's GDP, or the term GDP, means all the money that a country makes in a year. And Nigeria's GDP is around $375 billion to $400 billion. So that's all the money that all 180 million of us produce in a year, about 400 billion. The UK has just about 60 million citizens, but they spend 200 billion, that's half of our GDP, on healthcare every single year. Nigeria's entire budget is about 20 billion, and that has to cover everything that we do. The healthcare budget in Nigeria is about $1 billion. So that means that it would take us 200 years of our healthcare budget to be able to accumulate what the UK spends on healthcare in a single year. To make matters worse, our budget has very severe fiscal constraints. So when most developed countries set their budgets, the budget money has been collected and is usually somewhere in an account waiting to be spent. When Nigeria passes its budget, usually about 3 to 6 months into the year, we actually don't have the money in the budget. So all that fighting, all those arguments, all those different debates between the legislature and the presidency are really arguing over fictional money that we then have to go out and go and look for. So I'm sure you've read in the news that we're raising now a $2 billion Euro bond. We're raising that bond at almost 10% interest, and that is to fund our budget. The current state of our fiscal affairs means that almost 70% of the budget, even when we get the money, has to be allocated to paying back debt that we've already taken, leaving only 30% for everything else we want to do. A huge proportion of that 30%, as you all know, is used to pay salaries. So we don't really have anything left for healthcare, education, infrastructure, social safety nets, and all the other things that we need to do as a country. So this is actually one of the Dangote winners in the market. I'm running out of time, so I'll make my final point because this relates to my current work, which is about Obajanas, or big hospitals. As you can see from the evidence behind, from trauma cases, to stroke cases, to pediatric cases, to neonatal surgery cases, patients actually do better when they are critically ill in facilities like the Obajanas of this world that take a large number of patients with a large number of healthcare workers that are super specialized in what they do. In fact, there's good evidence in some of these journals that shows that it is better to bypass a non-specialist hospital to get to one of these big Obajanas where patients can be adequately taken care of. And it also shows that the cost of care in these large hospitals is far cheaper than our fragmented system today, where we have a lot of hospitals that don't really function that well and are under severe fiscal pressure because of the constraints of the budget that I discussed in the earlier slide. So the purpose of this TED Talk for me is to really get people tweeting, going to see their local politicians, writing letters, and really thinking about how we can solve this big problem of healthcare. Because like I said at the beginning, it's something that has affected and will continue to affect our friends, our mothers, our kids, all across Nigeria. And fixing this problem, for every $1 invested in healthcare, you get $2 back into the economy. So fixing this problem is really the key to not just creating healthier Nigerians, but actually a healthier West African population. Thank you.